or used to panic times, panic times.
Dear participants, please keep your audio settings off to avoid disturbances. Dear participants,
Dear
please keep your
participants,
audio
please
settings
keep your
off to
audio
avoid
settings off to
disturbances.
avoid disturbances.
Vaishnavi, please keep your audio
Vaishnavi, please
settings
keep
off.
your audio settings off.
So have you joined? We will wait for five
We'll
more
wait for
minutes for
5 more minutes for
other
other
participants to
participants to
join and
join
then
and
start
then
the
start the
session.
session. Thank you.
Good evening, everyone. I, Tapashri from the Skybook team.
This conference will now be recorded.
Good evening, everyone.
Good evening, everyone. I, Debushri from the Skybook team, would like to welcome you all for today's session.
Today's webinar
On Mycobacterium tuberculosis infection is brought to you by the team Skybook.
Speaker of today's
Speaker of today's webinar is Dr. N. Ashok Vishwanath.
Before starting the
Before
webinar,
starting the webinar, it's a humble request to everyone to please keep your audio and video settings off in order to avoid disturbances during the session. Also, filling of the feedback form after the session is over is mandatory.
Now, I would
like to introduce you all to our guest speaker.
Dr.
Dr. Ashok has a degree in MBBS, MD, DNB, MNAMS, and has a PG diploma in infectious diseases.
He is currently
He is currently working as an assistant professor in clinical microbiology department and is a consultant clinical microbiologist.
Coming to his
achievements, Dr. Ashok has achieved distinction in MD degree exam, All India first in DNB degree, June 2020 session with the specialty of microbiology and is also awarded President National Board of Examinations Gold Medal at New Delhi. Sir, I would like to thank you for taking the time out for speaking in today's webinar. It's an honor and privilege for our team to host this session.
Now, I
would request you to take over the session. Over to you, Dr. Ashok. Thank you.
Okay, thank you, madam, for inviting me for today's webinar. Are you all able to hear me well?
Yes, sir, you are audible.
Yes, sir, you are audible.
Okay. So, good evening, everyone. I wanted to thank the Skybook team and the participants for attending today's webinar. And today's webinar, it's all going to be on the topic tuberculosis. So, let us go into today's topic now. Were you all able to see my screen now?
Yes, sir.
Yes, sir.
Okay. So the participants for today's session are from medical stream and allied health stream, and also from other field like IT, engineering, and media. So I will try not go into deep into the medical and the surgical science. And with this, we will all go into today's topic today. So today's session is all about tuberculosis. So actually, it is going to be a bacterial disease which is caused by the organism called Mycobacterium tuberculosis, and the history goes back to 1720 when it was discovered to be a causative etiology of a deadly infection, and it was not named during that particular time, and the etiological organism was not known during that particular point of time, and it was discovered by the scientist named Robert Koch during the year 1905, for which he was awarded Nobel Prize in Medicine. And till 1960, the rate of infection and the death was so high that the advent of first antibiotic like isoniazid and rifampicin, after which the survival rate started to increase and the prognostic rate started to improve. Now, with advancing technology and diagnostic instrument, we are able to diagnose the disease much faster and also able to provide with the latest antibiotic treatment. So with this, we will see about the current scenario in our country and India. So the burden of TB in India is quite high. The incidence of tuberculosis is around 200 per 1 lakh population. And with a very good rise in the lifestyle disorder like use of alcohol, cigarette, and other endocrinological disorders like type 2 diabetes mellitus, the rate of tuberculosis infection is also rising, and with the development of various variants like multi-drug resistant TB and XDR TB, which is called as extensive drug resistant TB. So we call it the particular TB bacilli as multi-drug resistant, and the particular TB bacteria is resistant to the primary antibiotic like isoniazid and rifampicin, which is going to be an antibacterial which we use to treat a TB patient. And we also have something called XDR TB, where the TB bacilli is resistant to isoniazid, rifampicin, along with other antibiotic like fluoroquinolones and aminoglycoside. So this is called as the XDR TB. So with the rise in these kind of lifestyle disorder, we are seeing a lot of cases of this particular infectious disease. along with the various these kind of variants, which is going to be giving us a threatening environment. Okay, so in India, like it accounts for around 41%, and the largest share of the global burden is around 27%, which is contributed by the India, followed by China, and then the Russian states. So in India, like the current case scenario is going to be like an active case rate of it's going to be like around more than 41%, which is quite high for our Indian setup. And with the various strategies, we should make sure like we are going to eliminate TB by at least 2030. Okay, now like we'll move on to the route of transmission. So before going into the route of transmissions, can anyone tell like what is going to be the route of transmission? Regarding the particular infection, like we say something called route of transmission. So what is route of transmission? Can anyone tell? Okay, so yes. Okay, the route of transmission, like it's a mode. Yes. So the route of transmission is the rate by the route by which the particular organism is going to transferred from one particular patient to another normal healthy human. So that is going to be the route of transmission. And pertaining to the infection, like we study about the route of transmission. The route of transmission for different infections is going to be different. In case the route of transmission for HIV is going to be through sexual route and bloodborne route. In case if it is going to be COVID, it's going to be the respiratory route, predominantly the inhalation. And again, like tuberculosis is again due to the inhalation of the contaminated aerosol or droplet nuclei. So whenever like the infected patient, when he is going to cough out or sneeze, like he is going to produce the respiratory droplet, which is going to be contaminated with the particular tubercle bacilli. And again, like when we are going to come in contact with those kind of respiratory droplet, like we are going to inhale that particular thing into the lung. And inside our lung, like it depends upon our fate. In case of our immunity is going to be good, nothing will happen. There can be like a mild infection, like a mild asymptomatic infection, and our body can recover from itself. In case if our immunity is going to be very low, or if we are going to have any underlying risk factor, like we are going into the state of severe complication where the particular organism can escape the phagocytic system and can cause lung damage and also the extra pulmonary involvement. So whenever the particular bacteria is going to infect the lung, it is called as the pulmonary tuberculosis. When it is going to escape from the lung to the other organ or other state, so we call it as an extrapulmonary infection. Okay, so let us go into the risk factor for tuberculosis. So like whenever we talk about a particular infection, we have something called risk factor. So most of the time, like most of the infection, like we don't get it easily. There can be a certain risk factor which is going to raise the risk of getting the infection. In case if it is going to be of tuberculosis, like we have these 7 risk factors. We have the alcohol use, then we have the cigarette smoking, we have malnutrition, we have primary immunodeficiency disorder, we have secondary immunodeficiency disorder, we have the transplant patient and the not vaccinated individual. So we will see one by one. Yes? Are you all able to hear me better?
Yes, sir.
Yes, sir.
Yes, sir.
Okay, so I'll continue my lecture. So the first one is going to be the alcohol use. So it is notorious that alcohol use is going to raise the risk of tuberculosis by 68%. And again, like whenever like we are going to use alcohol, like our reticuloendothelial system is going to get damaged, and whenever like our reticuloendothelial system, like spleen or liver, is going to get damaged, our cell-mediated immunity and our humoral immunity is going to go down, and it is going to attribute to high rate of failure of phagocytosis, where the particular bacteria is going to escape the WBC in the lung and it's going to cause the infection. So that's about the alcohol use. And the second thing is going to be the cigarette smoking. So cigarette smoker, like what it will happens is that the particular ciliary mechanism by which the particular organism is going to be sent out. So whenever a foreign pathogen going to enter our respiratory route, that is going to be something called cilia, which is going to have a movement, and that particular cilia is going to send that organism out by the mechanism like coughing or sneezing. So whenever there is going to be a cigarette smoker, like depending upon the amount of cigarette he smoke, what happens is that there is going to be varying degree of damage to the cilia. Okay. And due to the damage to the ciliary epithelium, what is going to happen is that the particular organism which is going to go inside the particular lung, it is going to escape our WBC and it's going to cause infection inside the lung. Okay, that's about the cigarette smoking. And the third thing is going to be the malnutrition. So in our previous lecture, like we have studied about the various vitamins and minerals which helps us in escaping various infections. And again, like when the particular, in case of malnutrition, there is going to be deficiency of the vital protein, then vitamin and mineral. Due to the deficiency of those elements, our cell-mediated immunity is going to go down. And with following the cell-mediated immunity, the humoral immunity is also going to go down, and we are going to get the infection in the higher rate. So that is about the malnutrition. And the fourth thing is going to be the primary immunodeficiency disorder. So we call this condition as primary immunodeficiency disorder, where we are going to have some sort of cell-mediated or humoral immunodeficiency disorder. Most of the time, it's due to the genetic disorder like SCID or severe combined immunodeficiency, or even the other kind of cell-mediated immunity and humoral immunity. So immunodeficiency disorder, that's called as primary immunodeficiency disorder. And we have something called secondary immunodeficiency disorder. So secondary immunodeficiency disorder is nothing but an immunodeficiency disorder which is developing secondary to something else. It can be an uncontrolled type 2 diabetes mellitus. The patient can be suffering from an untreated HIV infection, ultimately leading to AIDS. So those kind of patients, they can have something like a secondary immunodeficiency disorder. And the transplantation. And once again, the transplant patient, like in order to avoid graft rejection, like we are going to put the patient on various immunosuppressive drug. So like when we are going to put the patient on immunosuppressive drug, their cell-mediated immune mechanism is going to get hampered, and due to the failure of the cell-mediated immunity, we can have a high rate of infection with an opportunistic pathogen. So one of the opportunistic pathogen in our Indian setup is going to be the tuberculosis infection. And non-vaccinated individual is going to be the seventh last risk factor. So like nowadays, like we are not having this not vaccinated list, because like whenever a newborn is born, like we are going to give the vaccination. Like the vaccine is going to be called as BCG vaccine or Bacillus calmette-guerin vaccine. So whenever a newborn is born, we are going to give this particular vaccine. And this vaccine is not going to prevent from the infection, but it is going to prevent from the complication that can arise from this tuberculosis. So severe form of tuberculosis can be avoided in those who are vaccinated. So this is about the various risk factor for tuberculosis. So with this, like we'll move on to the symptom. So symptoms are those in which the patient is going to present to us. So that is going to be the symptom. And following the symptom, like we are going to elicit certain signs on the patient that are called as a sign. So let us see about the symptom one by one. So here, like we have the 6 common symptoms which the patient can present in case of tuberculosis. So the first thing is going to be the fever, especially the evening fever. So the patient can be coming to us with. So in case if the patient is going to have evening rise of temperature, it is like more towards something like a tuberculosis or other thing like lymphoma, which is going to be a malignancy. So most of the time, these two illness are going to present with a condition called evening rise of temperature. So following evening rise of temperature, the patient can have something like a loss of weight and loss of appetite. So those loss of weight and loss of appetite can be due to the malnutrition or some other thing, which has a propensity to have a high rate of development of tuberculosis. And patients who are having cough for more than 2 weeks without any obvious cause, so that can be one of the symptoms. And patient can have blood in the sputum. So again, patient can present to us with a condition called hemoptysis, where the patient can cough out blood. And there is something called extrapulmonary tuberculosis. So as I told before, like when a particular organism enter our lung, it is going to stay inside the lung and it's going to cause lung infection. That's called pulmonary tuberculosis. And sometimes from the lung, the particular organism can disseminate to the other part of the body, where it can cause something called extrapulmonary tuberculosis. So it can be something like a renal TB or brain TB or ocular TB, or it can be even like pleural TB. So there are like many tuberculosis which can be involved by the Mycobacterium tuberculosis. So those are called as extrapulmonary. Like most of the time it's going to be pulmonary, but in case if our cell-mediated immunity and humoral immunity is going to be very low, the patient can go into the disseminated form of tuberculosis, which is also called as extrapulmonary tuberculosis, which is going to have a high amount of complication, and the prognosis rate is also going to be very poor in case of other type of tuberculosis. Even the treatment is going to be like for a longer duration in case of extrapulmonary tuberculosis. And example for extrapulmonary tuberculosis, as I told, like it's renal TB and brain TB and ocular TB. So these are the types of extrapulmonary tuberculosis. So with this, like we will move on to the clinical finding, which we can see in those patients. Okay. So now, like whenever like we are going to have a patient who is going to have like these kind of symptoms, the first non-invasive test which we do is going to be the lung X-ray. In case if you are going to take a lung X-ray, we are going to see these kind of findings. So this is going to be a normal X-ray where we are going to see the normal lung shadow, cardiac shadow, and the trachea is in the straight line. So this is the particular normal chest X-ray. So with this finding, like I will also discuss about the pathogenesis. So now, like you just imagine, we are going to inhale a bacilli, TB bacilli into the lung, and the TB bacilli is going to reach the lung. So what is going to happen is that when the particular bacilli is going to go into the lung, like there are various mechanisms by which the particular organism can get killed. So most of the time, around 80% of the time, like our body will take care of that particular bacilli. Nothing will happen to us. So most of the time, like the particular bacilli will get destroyed in the lung by various mechanisms, and our ciliary mechanisms are there by which the particular bacilli can be sent out of our body. And most of the time, we won't develop any infection. But sometime, in case of if our immunity is going to go down, in case if you are going to be in a state of malnutrition, we can undergo the various pathogenesis. So the first pathogenesis that can happen is going to be something called as Gaunt's focus. So there is going to be something called Gaunt's focus, where in the right lung you will be able to see a small calcification. So that is going to be the Gaunt focus. So whenever the TB bacilli is going to go inside, the WBC comes in contact with that particular TB bacilli, and that particular TB bacilli gets locked by the WBC. That particular area will get calcified. So that is going to be the Gaunt focus. Again, like many of the patients with Gaunt focus, they will go for spontaneous clearing. So most of them with the Gaunt focus will not require any treatment. So most of them, they will subside automatically without any treatment. If the immunity is going to be better, like it will not progress further. So sometime what infection. So those kind of patients with Gaunt focus with the symptom, like we need to treat the patient. In case after the Gaunt focus, something is going to okay. Okay, we'll continue the lecture. So we have something called as Gaunt's focus. So in the Gaunt's focus, like we have the calcified mass here. So most of the time it's going to get cleared. It's going to get cleared, and what is going to happen is that so following the Gaunt's focus, there is going to be the involvement of the hilar lymph node. So this is going to be the hilar lymph node where after the infection with the okay, can we switch off the audios? Okay, so we will move to the second pathogenesis, that is the involvement of the hilar lymph node. So with the calcified mass, with the Gaunt's focus, the patient can have an involvement of the hilar lymph node, where the hilar lymph node is going to get enlarged. So adjacent to the Gaunt's focus, there is going to be the involvement of the lymph node in the hilum area. So that's going to be the hilar lymphadenopathy. So certain patients post Gaunt's focus, they can go for something called hilar lymphadenopathy. So here again, the most of the time it can get cleared spontaneously, but most of the patient is going to have a healthy immune system, like they will clear this particular infection. In case if their immunity is going to be very low, again like this particular hilar lymphadenopathy will have a symptom. Again, like these kind of cases has to be treated. So following Gaunt's focus, like we have something called hilum lymph node, so which is called as hilar lymphadenopathy. So in case after the hilar lymphadenopathy, what can happen is that the patient can go to a particular condition called miliary tuberculosis. So in miliary tuberculosis, like you are able to see a lung X-ray with numerous opacity all over the lung. So almost like you are able to see more than 10 to 15 opacity. So this is going to be the miliary lung tuberculosis, where the particular TB bacilli has destroyed most of the lung and lung. So here, like it is going to be a miliary lung tuberculosis, where the patient may have a lung failure, or the patient can even have death due to the lung failure following the miliary lung tuberculosis. And again, like it is going to be highly extrapulmonary tuberculosis. So extrapulmonary tuberculosis, like I will show you certain common tuberculosis which we see around. The first type is going to be the pleural TB. So pleural TB, like below the right lung, you are not able to see any lung area. So there is going to be an opacity area. So that's going to be the pleural space. So following the lung, the particular TB bacilli can reach the pleural cavity, where it can cause something called pleuritis, and there can be fluid accumulation. So that is going to be the pleural tuberculosis, and it is one of the most common type of extra pulmonary tuberculosis, which is called as pleural TB. So following pleural TB, the second TB that we can see in our setup is going to be the ocular TB. So in ocular TB, like the particular TB bacilli can involve the eyes. It can start from the cornea till the optic tract, like anywhere it can cause the involvement. And the most of the time is going to be a condition called tuberculous choroiditis, so where the particular eyes can get damaged. Here the patient can present to us with the complaint like visual disturbances or sudden visual loss. So the patient can present with those kind of things. Again, like we will do certain examination like fundoscopic examination or ophthalmoscopy to visualize what is happening.
So we'll be visualizing, like we'll be seeing if any abnormalities is there from the anterior to the posterior side of the particular eye. So this is about the ocular tuberculosis. And the third most common TB in our Indian setup is going to be the renal tuberculosis. From the lung, like the particular TB bacilli can enter the blood vessel. From the bloodstream, it can get locked in the kidneys, where it can produce something called renal tuberculosis. And renal tuberculosis, like it can be either unilateral or bilateral. Unilateral in the sense only one kidney, so that's going to be the unilateral. In case if it is going to be bilateral, it is going to be both the kidney involvement. So here, the particular patient can have an infection of kidney. So following kidney infection, the particular patient can excrete the particular bacilli in the urine, where we can detect the particular TB bacilli in the urine of the particular affected patient. So we have something called 24-hour urine testing, where we collect the 24-hour sample, the particular urine sample of the particular patient, and we will be testing for TB bacilli. We will be seeing if any TB bacilli is there or not. So this is about the renal tuberculosis. And we are moving to the brain tuberculosis. Sometimes what happens is that the particular TB bacilli from the lung, it can reach the blood vessel. From the blood vessel, like it can go to the brain, where it can cause like a severe form of tuberculosis, like tubercular encephalitis or tubercular meningitis or tubercular brain abscess. So this is about the brain tuberculosis. Again, like it can be a life-threatening condition. So the prognosis rate for brain tuberculosis is very poor. Like in case if you are not going to treat these kind of patients at the proper time, like there are more chance of death in these kind of patients. And we have something called abdomen tuberculosis. So most of the time, abdomen tuberculosis, it will be seen in children. So what happens is that the children may have a lung TB and they have produced mucus. The sputum can be produced. So children, they don't spit it out like an adult. So in case like if you are going to get cold, if you are going to get the sputum or mucus in the throat, like we will be like spitting it out. In case if it is going to be pediatric children, what they will do is that they will engulf the sputum. So they won't spit it out. So what will happen is that from the bacilli from the lung, it can reach the abdomen, and in the abdomen, they can cause something called abdomen tuberculosis. So there can be like varying forms of abdomen tuberculosis, like a particular mass-like thing. The patient can go for intestinal tuberculosis, intestinal obstruction, mesenteric lymphadenitis. So there are like many things. So here, the grossly, the abdomen is going to get affected, and the presentation can be varying depending upon the involvement of the structure in the abdomen. So that's going to be the abdomen tuberculosis.
This conference will now be recorded.
Pediatric population, not merely in the adults. So next we are moving into the spine tuberculosis. So in spine tuberculosis, a particular bacilli from the destroy all the bone structure. So here the patient can present to us with a complaint which is suggestive of fracture. So there is going to be the destruction of bones of the spine, and here they are going to come to us with the bone destruction, and there can be collection of pus in that particular area, or it can be something like an psoas abscess or any other tracking abscess, which can be from that particular area. So that's going to be the spine tuberculosis, or we call it as a pot spine disease. So again, like it can cause varying grade of deformation. So it depends upon the bone it involves and also the bone space involvement. So this is about the spine tuberculosis. And the most commonest after the pulmonary tuberculosis, what we see is going to be the lymph node tuberculosis, where the lymph node adjacent to the lungs are going to get involved. It can be an axillary lymph node, or it can be cervical group of lymph node, where the patient usually comes to us with a complaint of swelling in the neck or the armpit region. So here the lymph nodes are going to get involved. So here the bacilli is going to, from the lung, it is going to reach the lymphatic system, and from the lymphatic system, it's going to reach the lymph node. And here, like they are going to cause an infection. So that is going to be the lymph node tuberculosis. So this is the second most common which we see in our daily routine following the pulmonary tuberculosis. Okay, so these are the various types of tuberculosis which we see in our daily routine. Like there are like lot of types of tuberculosis, but these are the most common which we see in case of tuberculosis and extrapulmonary tuberculosis. And we also see other type of tuberculosis like hepatic tuberculosis, and we have something called skin tuberculosis, and we also have like several types of tuberculosis. Like these are the like various forms of commonest pulmonary and extrapulmonary form of tuberculosis. So with this, like we will move into the testing and various procedure that is done for diagnosing this particular TB infection. So first we will see about the lung tuberculosis. So in lung tuberculosis, the particular organism is going to stay in the lung. So here it is going to cause the infections of lung that can be ranging from advanced focus, then hilar lymphadenopathy, and then we have the various forms of pulmonary tuberculosis like miliary tuberculosis, and these are the various forms of tuberculosis. So what sample we collect is usually going to be the sputum. So we usually collect two sputum sample. So two consecutive sputum sample. So most of the time the shedding of that particular TB bacilli in the sputum is going to be very low. So in order to confirm, like we collect and test the first sample followed by the testing of second sample. So in case the first sample is going to be negative, we are going to do the same testing on second sample, and then we are going to release the report as negative. So this is about the testing strategy which we follow. So we follow something called NTEP testing protocol. So we have something called National Tuberculosis Elimination Protocol. So in case it is going to be lung tuberculosis, most of the time it's going to be sputum. But in case what can happen is that we will not be able to see the particular bacilli in the sputum. So in those kind of condition, like we are going to do something, is a procedure by which we are going to introduce the bronchoscope into the lung, and with the help of the bronchoscope, like we are going to instill some normal fluid into the particular trachea and larynx, and we are going to again aspirate that fluid, and we are going to analyze that particular fluid for the presence of that bacteria. So that is called as ball fluid or bronchoalveolar cover. So we are going to and we are going to see if any bacilli is there or not. So this is about the lung tuberculosis. And the second thing is about the pleural TB. So in case of pleural TB, like what's going to happen is that there is going to be the collection of pleural fluid in the pleural cavity. So again, like with the help of CT or ultrasound guided thing, like we are going to do the pleural tapping with the help of a needle, and we are going to collect that particular pleural fluid, and we are going to check if any organism is there or not. So that is about the pleural TB. Here we are going to do the pleural fluid aspiration, and we are going to study the particular pleural fluid for the presence of any Mycobacterium tuberculosis bacteria is there or not. Now moving on to the lymph node FNAC. So here, in case if the patient is going to present to us with a complaint of any swelling, like any lymph node involvement or any swelling in the neck or the armpit region, like we are going to clinically examine the patient. In case if it is going to be FNAC, like we need to come up with the provisional diagnosis. We must know whether it is going to be an first lymph node or not. In case if it is going to be a lymph node involvement, we need to know whether it is going to be an infective etiology or non-infective etiology. There are certain non-infectious etiology like lymphomas. There are like various type of lymphoma like Hodgkin lymphoma, non-Hodgkin lymphoma. Again, with a clinical examination, like we'll be able to come to a conclusion whether it's going to be an infectious etiology or non-infectious etiology. Again, in infectious etiology, like there are like various infectious etiology, and TB is going to be the most commonest, and we need to rule out the other commonest etiological thing. The patient can be having something like a dental caries or any ear infection. So due to that particular infection, that can be an lymph node enlargement. So those kind of patients, we don't need FNAC. So most of them, they will respond to the empirical antibiotic, but still lymphadenopathy, that is lymph node FNAC. In case of tuberculous lymphadenitis, we do this procedure called FNAC, or we can even do the procedure called true cut biopsy, where we are going to take the specimen from the particular lymph node, and we are going to study that particular specimen for any gross pathology and the microscopic pathological feature. If there is any pathological features of that particular tuberculosis, like caseating granulomas there or not. So this is about the lymph node FNAC, which we do for tuberculous lymphadenitis. So next we are going to move to the fluoroscopic guided biopsies, which we do for tuberculosis like bone. So in case if there is going to be an involvement of bone like spine TB or part spine, we are going to take that specimen from the particular involved area. So we can use something called fluoroscopy. With the help of fluoroscopy, like we can introduce the particular biopsy needle and we can take a specimen from that eroded area and we can study the particular specimen for the presence of any organism, if there is any organism is there or not. Like with the help of fluoroscopy, like we are going to take up the specimen and we are going to study that specimen for the presence of organism. So this is about the fluoroscopy guided biopsy, which we done for something like an bone tuberculosis or something like a spine TB or pot spine. And we are moving on to the abdomen TB. So here we have studied about the abdomen TB. Most of the time it's going to be seen in pediatric age group, but it can also be seen in adults. So in case pediatric, like they are going to swallow the contaminated mucus from the lung, like they are not going to spit it out, they are going to swallow the sputum. So the bacteria is going to go into the stomach and intestine where it is going to have an involvement. So this is going to be an abdomen tuberculosis. In case of abdomen tuberculosis, like most of the time, like we do something called diagnostic laparotomy or diagnostic laparoscopy, where we are going to introduce the laparoscopic probe and we are going to study for any features of tuberculosis. So there is going to be anything like fibrosis or not. In case if there is going to be anything like an abdomen tuberculosis, like there will be some future which is going to tell us if there is going to be any tuberculosis or not. So after introducing the probe, like we'll be able to see if there is any fibrosis or any free fluid is there or any minimal ascites is going to be there or not. So in case if there is any finding, like again, like we are going to take a biopsy from that particular area and we are going to study the particular specimen if there is going to be any organism or the. In case if there is going to be anything like a free fluid or ascites, again like we are going to obtain that particular specimen from the peritoneal cavity. Again, like we are going to analyze the particular specimen if there is any organism or not. So if there is any organism, again like depending upon the grade, like we'll be treating the patient. And in case if there is not going to be any organism, again like we can do some other procedure with which we can even detect a minimal amount of organisms present or not. So we will see in the next sessions. So now coming to the lab diagnosis. So here, in case of infectious etiology, the lab diagnosis is going to play a major role, which is going to give a hint about what we are dealing with. So this particular TB infection is most of the time they are going to mimic the malignancies. So most of the patients they can present to us with a complaint like blood in the sputum or blood in the urine. So it can be TB or it can be something like a malignancy. So like it is very essential to rule out the particular infectious etiology so that the treatment part is going to be different for each of the etiology. In case if it is going to be infectious, like we need to know whether it's going to be a TB or it is something else, or it is going to be a non-infective etiologies like anything like leukemia. So we doesn't know what we are going to deal with. So here the lab diagnosis will give us a better idea for better treatment. So we will see one by one. So the first test which we do is called as a TB skin test, which is called as Mantox test. So here, like we are going to inject the purified protein derivative. So is there any medical student who can tell about this particular test? So is there any medical student here, like who can tell about the skin test for TB? Okay, so there is something called the Mantox test where we are going to inject the purified protein derivative into the skin and we are going to check for the erythema and induration. In case there is going to be an induration more than 10 millimeter, it's going to be a positive Manto test. So we are going to inject the protein which is derived from the tubercle bacilli into our forearm and we are going to check for the induration after 48 hours. So in case if there is going to be an induration, if there is going to be a swelling which is seen after 48 hours, we are going to measure it. And if the measurement is going to be like more than 10 millimeter, we tell it as positive, which is going to tell us if we are going to get exposed to the TB bacilli or not. So it is not useful for infection, but it's going to tell whether we are going to get exposed to the TB bacilli or not. And it will not be able to tell us again, like if we are going to have something like an active infection or latent infection. Again, this particular test can come positive in case if we are going to get vaccination like BCG vaccination. So BCG post BCG vaccination, again this particular test can come positive. So it is going to be a screening test which is done for tuberculosis. Now we are going to the other non-invasive tests. So we have something called a TB quantiferon gold test, where we are going to collect the blood sample and we are going to do the quantiferon test, where we are going to analyze a particular specimen for the presence of something like interleukin. So in case if our body is exposed to the particular infection, they are going to produce a certain interleukin, and those interleukins, like those presence and their quantification, can be studied with the help of this particular quantiferon test. And the sensitivity and specificity is not that good as like a microscopic and other study. But again, like it can serve as a screening test, and it can tell about the exposure. So to some extent, it can tell about the latent infection and active infection, but it will not be helpful for diagnosis. Again, these two, the Mantox skin test and the TB quantiferon gold test, is going to be an screening test for tuberculosis. And this is going to be one of the specific tests. So in case if you are going to get a specimen like a sputum or any pus sample from the particular inflamed lymph node, like we can do something called Zeal-Nielsen acid fast staining, and it's going to be one of the sensitive and specific tests. So here, like you are able to see a blue background. So those are all pus cell. You are able to see small round cells. So those are the pus cell, and you are able to see a pink bacilli. So that is going to be the TB bacilli. So here we are going to check the ability of the organism to produce something called mycolic acid. So with the help of mycolic acid, it will be resistant to decolorization with acid and alcohol. So the particular bacilli at the end of the particular test, that particular bacilli is going to look pink, and the background is going to be blue. In case it is going to be a pus cell or any other organism, it's going to be blue. And in case if it is going to be a TB bacteria, it is going to appear pink. So this is going to be an acid fast bacilli. So this particular image is going to be an smear which is positive for acid fast bacilli, possibly Mycobacterium tuberculosis. And other thing which we can do is going to be the fluorescent microscopy. Again, like we are going to obtain the specimen, and we are going to use certain special stain, like which are fluorescent in nature. And again, like at the end of fluorescent staining, like we are going to visualize that particular smear under fluorescent microscopy. So in case if the particular specimen is going to contain the TB bacilli, there is going to be a fluorescing bacilli. So here, like you are able to see a light green background, and you are able to see a strongly fluorescing, like a thin rod-like structure. So those are the fluorescent, fluorescing TB bacilli, which is seen under the fluorescent microscopy. And now culture. So now we have seen about the particular organism under the microscopy. So we know presumptively the organism which we are dealing with is going to be the TB bacilli. Again, like we can do something like culture, but the disadvantage of culture is that the growth happens usually after 6 to 8 weeks. So we will not get the report within 6 to 8 weeks. So most of the time what happens is that with the help of gram staining report, like most of the time, like we will start the patient on treatment. And most of the time, like we will not rely upon the culture, but still the gold standard diagnostic test for this particular infection is going to be the culture. But most of the time, like we will start the patient on treatment with the help of the acid fast bacilli microscopic report. So most of the time, like we will do. In case if you are going to get a negative report, again, like but particular time, like we can do some other test like CBNAT or gene expert. Okay, so those are the other tests that we can do. And this is going to be the midget or mycobacterial growth indicator tube, and it is going to be one of the automated method for detecting the particular TB bacilli. Again, like it takes some time. It takes at least 4 to 6 weeks for the growth. The good thing about this particular thing is that in case of any positive growth, there is going to be an fluorescing. So most of the time, like we will take the particular tube which is inoculated with the specimen out, and we will be checking that particular tube for the fluorescence. So in case if there is going to be any fluorescence, like it is going to tell us if there is any presence of organism or not. So this is about the mycobacterial growth indicator tube. And most of the institutes, like they don't have this particular mycobacterial growth indicator tube. It's going to be a costly instrument, and only the higher center they are going to have this particular instrument. So this is called as MGIT, which is an automation in mycobacteriology. And we are moving to something called gene expert. So when we are going to deal with a patient who is going to have clinical features of TB, and we are going to do some tests like bronchoalveolar lavage aspiration, and we are going to do the bronchoscopy, and we are going to take the fluid out, and we are going to test it. In case if the bacilli load is going to be very low, what happens is that we won't be able to see any organism in the microscopic thing. When we are going to do the fluorescent acid fast staining or zeal needs an acid fast staining, like sometimes we won't be able to see any acid fast bacilli in a particular structure. So in case if there is going to be an very low bacillary load, so those kind of things happen. So those kind of suspicious case, we do something called CBNAT or cartridge based nucleic acid amplification test. So one of the most common test which we do is going to be the gene export test, which is an protocol type of that particular CBNAT test. And in case of very low bacterial load, this particular instrumentation, which is based on PCR mechanism, it is going to detect the particular organism and it's going to tell any resistance is there or not. So it is going to detect the presence of Mycobacterium tuberculosis and also going to tell us whether any resistance is there towards rifampicin and isoniazid is going to be there or not. So it is a better test to detect and also to determine the sensitivity of the particular organism towards antibiotics like rifampicin and isoniazid. So it will give us a better idea what kind of TB patient are we dealing with. So are we dealing with a routine patient with the TB, or are we dealing with a patient with a multi-drug resistant TB or extensively drug resistant TB? So as I told before, like we call the particular condition as multi-drug resistant if the patient is going to be resistant to isoniazid and rifampicin. In case if it is going to be an XDR TB or extensively drug resistant TB, the patient is going to have resistance to isoniazid, rifampicin, and other antibiotics like fluoroquinolone and aminoglycoside. So those are the group of antimicrobial. So those like which we call as an XDR TB. And the treatment for MDR TB and XDR TB is going to be different. It's not going to be the routine treatment. In case of routine treatment, like we go for the isoniazid, ethambutol, pyrazinamide, and rifampicin. In case if it is going to be a multi-drug resistant TB or extensive drug resistant TB, like we will be switching to other class of antimicrobial for these kind of patients. And this is going to be the pathological study. In case of severe organ involvement, like we are going to have a removal of that particular organ and we are going to study for the pathological examination. So here, like you are able to see two images. The first image is going to be the lung and the second image is going to be the kidney. So here, like we will be studying the particular anatomical organ in the gross section, where we will be able to find out the presence of caseating granulomas or any abnormality. In case of anything like TB, there is going to be an caseating granuloma, like which we study in the gross pathology. And we have studied something called microscopy. So once we do the grossing, we study the microscopic pathology. So microscopically, like we will be able to study the anatomical morphology of the particular cell. So here, like case of the particular tuberculosis, like again, like there can be an evidence of TB infection. So we will be able to see something like a giant cell or granulomas. So here, like you are able to see the clumps of cell, like those are the granulomas, and which is going to tell us if the patient is going to have an infection which is caused by tuberculosis or some other thing. Again, like there can be like these antibiotics, they will have their own side effect. So we usually start the patient on ATT or anti-TB drug, like depending upon the if you are going to put the patient on isoniazid, they can go to the nerve. In case if it is going to be ethambutol, it can affect the eyes. In case it's resistant TB and XTR TB, again the treatment is going to be different. So this is about the treatment which we give for the TB patient, and the duration of TB is going to be different for pulmonary and extrapulmonary. So pulmonary, like we give treatment for around 6 months. In case of extrapulmonary, we give treatment for around 1 to 1.5 years. So it depends upon the involvement of the particular organ and the patient's condition. So most of the time, in case it is going to be a 6-month therapy, like we give the first 2-month intensive therapy. After that, we give 4 months of treatment. That's going to be the continuation therapy. So we give the treatment under something called DOTS protocol. So directly observed treatment short course. So under the particular strategy, we give the treatment to the patient. So the government is giving the drug free of cost for those who are suffering from TB infection. So now moving to the prevention. So most of the time we can prevent the infection to some extent by various lifestyle modification, by avoiding something like alcohol or avoiding the smoking, and we can go for a healthy lifestyle and avoiding malnutrition by eating very good food which is going to be rich in protein, vitamin and mineral, and not taking something like a spicy food, or so those kind of thing can help us in